Thank you.
Good evening, everybody present here today, joining this webinar. First of all, I want to say that I am amidst dark. I am in Diffu. There is no electricity. With a small light, I am talking to you. We cannot meet in person due to this COVID crisis. I wish all of you are healthy and stay safe, first of all. And we are conducting this webinar along with Ecumentis Harmonica Division. So I welcome you all here. We have two eminent speakers, Dr. Ayana Bodhakur and Dr. Diganta Deka. They will be talking on endometriosis. And to conduct this session, I welcome today's person, Dr. R.K. Talukdar sir. He is principal, Guwahati Medical College. He was principal, Guwahati Medical College, professor and HOD of Guwahati Medical College ONG department. He was the president of Guwahati ONG Society, and also he was the organizing secretary of AICG 2010 Guwahati. Welcome, sir. Please go through.
Thank you, Navanita, for this long introduction. Anyway, I think, happy to be called a medical college teacher. I don't need anything else. Unfortunately, with my present thing, I think gradually I'll have to move away from teaching, which I don't intend to do, really. So I'll get back to that. Anyway, I'm very happy to be here and particularly taking part in a very, very pet subject. And I thank the Guwahati Obstetrics and Gynecology Society for letting me have this opportunity. And of course, Ecumentis, Subhajit, we have known each other for a long time. And, endometriosis is a really pet subject of mine, both in clinical problems as well as infertility. And we have two very eminent speakers today to talk about or give us everything about the knowledge about endometriosis. And the first one will be from Dr. Ayana Bodhakur. She is a practicing, noted, respected practitioner of obstetrics and gynecology at Guwahati. I think she did the medical director of the Ayurveda Hospital as well as the Bodhakur Hospital. And she is going to talk to us about the basics of everything about endometriosis. And then we have Dr. Diganta Deka, a brilliant academician whom we really miss from our medical colleges. But wherever he is, he's developed into a brilliant infertility specialist and IVF specialist. And half of his work is probably associated with endometriosis. Other half probably with PCOS. Today, these are the biggest problem in this sector. And he's going to tell us all the problems related to endometriosis in the management. So, Dr. Ayana Bodhakur, I request you to please go ahead with your talk.
So, good evening, sir. Thank you so much for such a kind introduction. And thank you, Ecumentis. Thank you, Guwahati Society, Dr. Nabanita and Ratnada today for inviting me here to talk on endometriosis. Again, a very favorite topic of mine. I'm very really interested in this very complex disease. And so I'll just start my presentation. Can you see?
Yeah, we can see it.
Okay.
Yes, ma'am.
So, good evening, everyone. Today I'm speaking on endometriosis, the basics of endometriosis up to management. Like I said, I was very happy when I was asked by the company to speak on endometriosis because it's a very complex disease, very, very interesting disease. And it has, and so much about it is known now, and so much still needs to be known. It is a multifactorial disease and a very complex disease. which is it is defined as the presence of functioning uterine glands and stroma in any site outside the uterus. The condition is one of unusual interest, and although it gives rise to tumor formation, that is a swelling, it's not a neoplasm. So it may behave like a neoplasm, it may look like a neoplasm, but it's not a neoplasm. But that does not mean that malignancy cannot develop. Ectopic endometrium can occasionally be the site for the development of a malignant growth, although this is uncommon. This disease occurs in two forms: extrauterine organs and tissues, or in the uterine wall. So either endometriosis or adenomyosis, which are believed to be two distinct entities. So it's a complex disease. It causes a lot of pain and morbidity to women, and is the subject of a lot of research right now, and is responsible for a huge socio-economic burden to society. So endometriosis significantly impairs quality of life, working efficiency, and sexual life. The main symptoms include severe dysmenorrhea, deep dyspareunia. So dysmenorrhea or severe dysmenorrhea or progressive dysmenorrhea is itself sufficient for diagnosis of endometriosis, I think. In most cases, we just get a clinical symptom of dysmenorrhea. Typically, this dysmenorrhea keeps on increasing, progressively increases from 1 day of dysmenorrhea to a pain which remains for all the 7 days or 6 days of menses, to a pain which can remain throughout the cycle. So starting with a cyclical pain, it can progress to become a chronic pelvic pain. And the pain keeps on increasing in intensity. So typically the patient or the woman says that earlier her pain was there only in the first day, later on now it's there throughout the cycle, or she used to take maybe one tablet analgesic, and now she has to take analgesics throughout the cycle. So progressive dysmenorrhea is a very particular symptom which is very significantly signifies the diagnosis of endometriosis. Deep dyspareunia, especially with infiltrating endometriosis or endometriosis of the rectovaginal septum. Not a very common symptom, but when there is deep infiltrating endometriosis, this can be a very significant symptom. Chronic pelvic pain, heavy menstrual bleeding or spotting between periods, especially with adenomyosis, painful bowel and bladder symptoms that occur during or before menstruation, and infertility. So two main bodies of symptoms, either pain in different forms of pain or infertility. So what is the link between infertility and endometriosis? Endometriosis is responsible for 50%, it is present in 50% of infertile women, according to one particular survey, and adenomyosis in 25%. So pelvic endometriosis is more commonly found involved with infertility than adenomyosis. But even in mild endometriosis, where there may not be much anatomical distortion, or then even the symptomatically it may not be very severe, it's still associated with a decrease in fertility as compared to other couples, normal couples. So what about the historical background? Endometriosis is considered to be a disease of the modern era of the 20th or 21st century, but there are references to endometriosis in some very older, much ancient documents from Egypt and from Italy, and of course the most famous one by Samson in 1921, who referred to perforating hemorrhagic cysts of the ovary or chocolate cysts of the ovary. And if you remember, Samson was the one who postulated the retrograde, the theory of retrograde menstruation as an originator, as one of the theories of origin of endometriosis. And if you remember, this is one of the oldest theories, and this is one of the theories which has remained till now, remained relevant till now. Lots of theories have come in between about the origin, and they have been debunked, not accepted, but this theory has remained. The number of publications after 1921 has increased exponentially, and over the last 30 years, especially, there have been a lot of research concerning endometriosis and its link to infertility, or how it causes infertility. The prevalence of India in 2010, the Endometriosis Society of India had took a huge survey with 2,500 gynecologists from all across India, and they found that more than 26 million Indian women between the ages of 18 to 35 are suffering from endometriosis, and 12% of adolescents are suffering from endometriosis, which is a very, very scary prospect for the future, for our future generations. And it was found from all ethnic and social groups. So this is the prevalence. As in general, in all through the world, the prevalence is in percentage. It's about 6 to 10% prevalence in women in the reproductive age group. So if we consider 15 years to 50 years, so between 15 to 50 years, 6 to 10% of women suffer from endometriosis. But if you take particular subsets of Indian women, that is women who are, say, attending a chronic pelvic pain clinic or who are attending an infertility clinic, you'll find the prevalence to be much higher, maybe definitely higher than 50%, may sometimes be as high as 70%, especially in specialized infertility clinics like Diganta runs. Like specific infertility clinics, I'm sure you must be getting very high prevalence of endometriosis. So this is a survey, this is a paper which looked at the age-specific point prevalence of diagnosed endometriosis, and they found a prevalence throughout from 15 years to 55 years, but the peak was found between 40 to 45, 4 years. Which have shown, especially nowadays, they are showing, studies have shown that maybe the peak may be in even younger women between 25 to 35 years of age. So what about the socio-economic burden? I think this is why this is getting so much importance, and there's so much research because of the huge burden to society, huge burden to the patient. First of all, the patient, huge morbidity burden, economic burden in terms of the medications. As we know, most of these medications are extremely expensive. It's a chronic disease with no sight of cure. So the woman needs to take medications to relieve her of pain. She needs to take medications throughout her reproductive life, which means a huge expense and diagnostics, repeated surgery. How many times we have seen ourselves as clinicians, that patients are coming to us with history of once or twice already being operated, and now they come to us maybe 10 years down the line and they come and ask us to get a hysterectomy done because they cannot tolerate the pain anymore. So the point is, this is a chronic disease which needs repeated treatments, maybe repeated surgeries, repeated hospitalizations, and which is why huge economic burden to the patient and to the society. And also in terms of when a lost working hours, the adolescent girl loses out on school days, the working woman loses out on her hours, in her productivity goes down. So all in all, a huge burden to society. There are different locations of endometriosis. The commonest one is, of course, the ovary. Apart from the ovary, the tubes, the uterus, the bowel, the bladder, the pelvic organs are the next common ones. And last, but even in distant organs like the diaphragm, pleural cavity, lungs, kidneys, also we may get ectopic endometriotic implants, but they're not very common. Vagina and vulva, scar. So the commonest are in the pelvic organs, but we can get in distant organs also. So what is adenomyosis? Adenomyosis is considered to be a distinct entity. It is a condition in which there is a growth of endometrial cells inside the uterine myometrium, usually more than 2.5 millimeter beneath the basal endometrium. It is associated with myometrial hypertrophy and may be either diffuse or focal. Microscopically, there are ectopic non-neoplastic endometrial glands and stroma surrounded by hypertrophic and hyperplastic myometrium. So endometriosis can be staged as minimal, mild, moderate, or severe. And this gives us an idea of the severity of the disease. And it depends on certain factors. Certain factors are taken into account, like location of the lesions, number of lesions, size of the lesions, and depth of endometrial implant. This was postulated by the AFS, actually, the American Fertility Society, in 1985, and they designed this pictorial graph to classify endometriosis. So this classification is obviously a surgical classification, and I don't know how many of you do it, but I know that I do not use this classification in a general way on a regular basis, but it gives us an idea about, it gives us a baseline, it gives us an idea of standardizing. How do we compare one endometriosis patient with the other? So it gives us an idea of the severity of the disease, and which is why we should keep this in mind. We should know about this graph to classify the severity of the disease. So we are supposed to mark the endometriotic implants on that pictorial graph. So the stage 1 or minimal endometriosis, typically there will be a few lesions, very peripheral, very superficial lesions, and usually there will be no adhesions. In mild endometriosis, there may be light adhesions, and there will be the implants may be slightly larger. In stage 3 or moderate endometriosis, there will be deep implants on the ovary, maybe chocolate cyst. So a chocolate cyst would come under moderate endometriosis, and there may be more. There may be other lesions, and definitely there will be a few adhesions. In stage 4 or severe adhesions, severe endometriosis, there will be deep implants, including TO, say typically what we find a TO lesion with adhesion, so that would come under stage 4. So what are the theories regarding endometriosis pathogenesis? So there are, like I said, there is a lot known, there's a lot of research going on, but we still don't know exactly how it occurs. There are theories that endometrial tissue, there is retrograde propulsion of endometrial tissue during menses into the pelvic cavity. There may be metaplasia of coelomic rest cells. There may be, there is definitely the role of estrogen, because it occurs in reproductive period. So we know that estrogen has a role to play. Environment, inflammation, genetics, yes, genetics probably also has a role to play, though we do not know the exact genetic period. There is no single gene which has been isolated. Lymphatic spread, hematogenous spread. So the most popular theory is that there is retrograde menstruation. Then comes coelomic metaplasia theory. There may be lymphatic and vascular metastasis theory. This came up because endometriotic implants were found in distant sites, like the kidneys, like the diaphragm, like the lungs. Rare, but it has been found in these places. So how could endometrial tissue possibly go by retrograde menstruation up there? So then came the theory of lymphatic and vascular metastasis theory. So possibly there may be different ways of spread of the disease, or start of the origin of the disease may be different for different types of endometriosis, is what is the thought now. The risk factors for endometriosis include a first degree female relative with endometriosis. So then comes the question, is it genetic? There is definitely a genetic predisposition, but no single gene has been isolated as of now. It definitely has a role it is linked to your menstrual cycle. The shorter the cycle, so if you have every 15 days, if you have menstruation every 15 days, heavy flow, long days, 5, 6, 7 days of flow, you are more likely to have endometriosis. If there is early menarche, late menopause, late childbearing, or nulliparity, these are risk factors. Pregnancy is considered to be a protective factor. Definitely, we all know that pregnancy is a protective factor. Then those with Mullerian anomalies, especially those which arise during the formation of the female reproductive organs, especially those which are obstructive in nature, like vaginal septum or imperforate hymen, and even acquired outflow obstructions, as for example in cervical stenosis. Here, of course, the mechanism is easy to understand, possibly because of the obstruction. There is more amount of retrograde menstrual flow leading to endometriosis. So, many of us have seen during laparoscopy, we frequently see that there is a collection of blood. If we are operating on a woman during her periods, then definitely, invariably, there will be some amount of blood in the peritoneal cavity. But so 90% of women have retrograde menstrual flow. But how come only a small number, only 10% of women ultimately develop endometriosis? So what happens to the rest 80%? So it is postulated that in most women and in most cycles, the endometrial implants which fall into the peritoneal cavity are phagocytosed by macrophages, or they undergo apoptosis, cell death, which is why, and cell death, and these are taken care away, they are cleared away by macrophages every cycle. But in certain women, this mechanism is deficient. The cellular immune response to autologous endometrial antigen is impaired, which allows translocated endometrial cells to implant at ectopic sites. And these endometrial implants, these implants itself stimulate a pro-inflammatory reaction. Cytokines are secreted. Cytokines work like immunomodulators. Cytokines promote endometrial further growth of endometrial cells, of angiogenesis, and of inflammation, angiogenesis and endometrial proliferation. So at the cellular level, this is another mechanism which is exciting a lot of interest now, that it is postulated that TIAR mechanism, the trauma tissue injury and repair mechanism, which is there in the peritoneum with other inflammatory diseases, like for example in appendicitis or appendicular perforation. This comes into play even in endometriosis, is the postulation that endometrial tissue or fragment, when it falls on the peritoneal cavity, it excites TR mechanism, which activates macrophages, it activates cytokines, and these cytokines, they stimulate proliferation, survival, and infiltrative growth of ectopic endometrium. They also stimulate release of or synthesis of estrogen, leading to a microenvironment, estrogen dominant microenvironment in the endometrium. So we have endometrial implants, and these are sensitive to the systemic estrogen, and these implants also at the local level also start secreting estrogen. So there's a very hyper estrogenic microenvironment at the cellular level. Also prostaglandins are secreted, which again promotes a pro-inflammatory state. So it is believed that these three distinct types of endometriosis, that is ovarian endometriosis, deep infiltrating endometriosis, peritoneal endometriosis, may develop their etiopathogenesis, and the way they develop may be completely distinct. They are probably distinct entities and may need tailoring of, even when we are thinking of managing them. So what are the biologic mechanisms that links endometriosis to infertility? there are many mechanisms. Of course, the most common one that we see with our naked eyes is the distorted pelvic anatomy in severe endometriosis with adhesions, with obstruction of the tubes, and ovarian cyst formation. But apart from this, at the microscopic level and even in minor degree of endometriosis, there is research has shown that there is altered peritoneal function, there is altered hormonal and cell-mediated function, which we have just discussed right now, endocrine and ovulatory abnormalities. There's this ovulation, so chocolate cyst or implants, even minor implants on the surface of the ovary affects ovulatory function. There is impaired implantation due to poor endometrial receptivity. Oocyte and embryo quality is poor in even in women with, especially in women with moderate to severe endometriosis, which is how it affects, I believe, ART, also ART success rates also. Abnormal uterotubal transport. So to diagnose endometriosis, the history, I would say history is most important. And we take the history gently and very exhibition of endometriosis, progressive dysmenorrhea, deep dyspareunia, dysphagia, chronic pelvic pain, infertility, and menorrhagia can be very typical. On clinical examination, there may not be any findings at all, or in major degree endometriosis, there may be an adnexal mass, definitely tenderness, decreased mobility of the genital organs, or there may be nodules in the pouch of Douglas, there may be nodules, bluish nodules in the vagina, which we may even see on speculum examination. Then investigations or basic investigations, there is nothing particular for diagnosis of endometriosis, but we have to do the basic investigations to rule out other conditions which may mimic endometriosis, like PID, pelvic inflammatory disease, or urinary tract infections maybe, or ectopic pregnancy. So other conditions have to be ruled out. Transvaginal sonography, that is a vaginal ultrasound, is the most important investigation, most important non-invasive investigation in the workup of endometriosis, and will give us a clear diagnosis in most cases. Then comes diagnostic laparoscopy and biopsy of suspicious lesion. This is the gold standard for confirmation of diagnosis of endometriosis. TVS, a vaginal ultrasound, a clinical examination will give us a suspicion, but for confirmation, you need to do a diagnostic laparoscopy and biopsy of suspicious lesion. Now, these are the NICE guidelines as far as diagnosis is concerned. Ultrasound, you should consider transvaginal ultrasound to investigate suspected endometriosis, even if the pelvic and abdominal examination is normal. It should be done to identify endometriosis and endometriosis, not to be used to diagnose endometriosis. So a normal endometriosis, a normal CA125 does not mean that endometriosis is not present, and a raised one also may be consistent with having endometriosis. So MRI, do not use pelvic MRI as the primary investigation to diagnose endometriosis in women with symptoms or signs suggestive of endometriosis. So MRI is not to be used for primary diagnosis, but it can be used to assess the extent of deep endometriosis involving the bowel, bladder, and ureter. So typically we usually do it in severe degree of endometriosis or in diagnosed endometriosis for planning the management. Laparoscopy is the gold standard. It should be done to diagnose endometriosis in women with suspected endometriosis, even if the ultrasound is normal. For women with suspected deep endometriosis involving the bowel, bladder, or ureter, consider a pelvic ultrasound or MRI before an operative laparoscopy. During a diagnostic laparoscopy, laparoscopic surgery for endometriosis should perform suspected systematic inspection of the pelvis, and you should consider taking a suspected endometriosis. Diagnostic laparoscopy should be done by so that we at least have two hand instruments to be able to mobilize the pelvic organs properly and to look at, to do a very systematic inspection, including the surface of the uterus, tubes, ovaries, the ovarian fossa, the vesico-uterine fold, the pouch of Douglas, pararectal spaces, the rectum, sigmoid, uterosacral ligaments, pelvic side walls, appendix, cecum, diaphragm, and biopsy if the biopsy should be done if the lesion is more than 3 centimeters. So the lesions may be as small as this, or it may be very severe. Of course, diagnostic laparoscopy has the problem that you need an expert surgeon who is experienced, who can identify and especially in deep infiltrating endometriosis, it may be even diagnostic laparoscopy may miss the diagnosis if they're under the surface of the peritoneum. So, but generally, studies have shown that diagnostic laparoscopy, when it is negative, it is fairly so if it's a negative laparoscopy, we can reassure the woman that you don't have endometriosis. But if it is positive, if we feel that there is a lesion, it needs to be confirmed with biopsy. And if the biopsy is positive, this is 100% confirmation. Then another a difficulty with biopsy is very often it is found that in very old endometriosis, the biopsy may come out negative, especially if there is a large chocolate cyst or with which has remained for a long time. There is death of the endometrial lining, the cell death of the endometrial lining. So the biopsy may still come out as negative. So and it may come as follicular, cell hemorrhage with follicular cyst or whatever. So these are the difficulties, but still diagnostic laparoscopy with biopsy is considered to be the gold standard and needs to be done in any suspicious cases. So to conclude, endometriosis is a hugely complex disease with multifactorial origin. It is the cause of so much pain and morbidity to the woman, cause of so much socioeconomic burden to the society, to the family. And I think the most worrying aspect is that young girls, we are seeing it more and more in young girls. There's increased prevalence in young girls. And it's especially very scary because young girls tend to, it tends to be missed. The diagnosis is missed in these young girls. And research has shown that it takes nearly 5 to 7 years. In young girls, diagnosis is missed for 5 to 7 years. An average of 5 to 7 years for diagnosis to be done. So for this, we need to have more awareness drives. We need to make our public aware of endometriosis. We need to make our fraternity, our doctors, our GPs at the peripheral level, or even our gynecologists aware of the incidence of, huge incidence of endometriosis. We need a high index of suspicion so that we can catch this endometriosis, especially in young girls, catch them young and catch them early. Thank you so much.
Thank you, Ayana. Thank you so much for bringing out the real problems in endometriosis. The diagnosis, as you have seen, the young people who are suffering. Most often we don't think of endometriosis when we get girls with pain, pelvic pain, and a lot of times even ultrasound doesn't show that they are having endometriosis. And laparoscopies are not done in every place. It's difficult. But another real problem is the treatment, because if you do not treat them properly, the prognosis of this disease is pretty bad. Because long time people treat this way, that way, or people do laparoscopic surgeries, which are incomplete surgeries with a recurrence. And every time you have recurrence, the fertility potential of that woman becomes very, very poor. So it's a big problem in treatment. And I think there is no one better than Dr. Diganta Deka who will tell us about the treatment part of and management part of endometriosis as we go. We'll get to the questions of if the audience has any questions come up, they are free to give the chat box and we'll get to them if we have time. I don't know how long we have the time. If we have the time, then we'll get to them next. So may I request Dr. Diganta Deka to then he start his presentation, please.
Good evening, sir.
Yeah.
And can you see the slides?
Yeah, we can see the slide.
Okay. Thank you for inviting this session to talk on this topic. Basically, I was given a topic of management of
endometriosis. Can we do it full screen, please?
Diganta, please put it on full screen.
Is it okay?
No, full screen.
Sir, the bottom button, the icon
You
which
see
shows the screen on the bottom, beside the minus sign, sir.
On the bottom of the
Beside
screen,
the
the wine
minus
glass.
sign.
Yeah.
Towards your right, sir.
The wine glass. Just
Yeah,
click
yeah,
the
yeah.
wine glass.
Okay.
Yes, sir.
Now it is okay.
Harass told the right thing.
The people will, Smriti, they'll understand what I'm
Yeah,
with
yeah.
wine glass.
Sure.
That's right.
So I was given a topic of management of endometriosis. This is a very huge topic, so it's not possible to talk on a very limited time. So basically, I will just focus on the medical treatment only. So basically, as you know, it's as my previous speakers has rightly said about the anemia of the disease. It's a very complex disease, and basically the managing the endometriosis is a lot of skill, right from the decision making and the treatment modality. So basically, in a simplified manner, there are two options we have. One is the surgical management, another medical management. So we have to decide on which group requires which treatment. One important thing about the surgical management, this is definitely one of the gold standard of the treatment for the diagnosis as well as the management. But 15 years back, it was we used to see a lot of cases for repeated surgery being done for endometriosis. But now it is a very well-known fact that in lifetime of a woman, if possible, she should be operated only once, and that should be a complete surgery if possible. Many a time it may not be possible, but we should strive to do a very complete surgery. That's why we should clear, choose the patient who actually surgery. So in case of what is the therapeutic goals in managing a case of endometriosis? Basically, we should understand the disease properly, and we should educate the patient about the disease development and what are the treatment options available, as well as we should try to alleviate their sufferings like pain, which is one of the most common features with the patient to the physician. Pain, then we should try to correct their bladder and bowel problems. Then we should try to focus on their physical fitness and helping their building their self-confidence and in improving functions and psychological support, because many of them patients are quite depressed. It is noted that the environmental factors, nutrition and exercise have a direct impact on female hormones and the menstrual cycle and the immune system. And studies have shown that women with endometriosis have a poorer diet than a healthy woman. We have seen that saturated fats, especially from the animal products like meat, milk, sausage, they flood the body with the arachidonic acid, which can promote inflammation and pain. And this probably should be avoided in case of endometriosis to alleviate the pain. A healthful diet is requires certain other ingredients like vitamins and minerals also. So as I have discussed that deciding the treatment modality, like which patient should need surgery. So if the patient has got a very weak mass, more than 4 to 5 centimeters, symptoms is very severe, and fertility is a concern, married, probably they need their choice is probably the surgery. And if the diagnosis is also not very sure, then also they need surgery. But young, adolescent, not unmarried, there we should try to delay the surgery if possible, because many a time this endometriosis is notorious for recurrences. Almost up to sometimes in case of grade 3 and grade 4 endometriosis, the recurrence rate may be as high as 45% also. So many a time the recurrence occurs after 6 months to 1.5 years after the surgery. So we should judiciously use this option. And in case of surgery, the main aim is to remove the cyst, inoculate it as far as practicable, and do a complete adhesiolysis. In medical management, the aim is to destroy or prevent the lesions for recurrence, and also to reduce the pain and improve the quality of life. So in this algorithm of medical treatment, we have seen that if possible for the diagnosis as well as for the treatment, laparoscopy is one of the gold standard or mainstay of the treatment. So after laparoscopy, either you can go for medical therapy or you may not give him any medical therapy. So how to decide on this course of action? So if the surgery is done for the purpose of fertility enhancement, then probably there is no role of medical therapy. If we can do a complete surgery, it is better to allow them to become pregnant as soon as possible, because that will have because within the surgery, within first 6 months, they have a very high fertility rate, which gradually decreases up to 1.5 years. But if the surgery is done for purpose of other than the fertility enhancement, like pain and other problems, then they should be given medical therapy to prevent the recurrence rate. For preventing in the medical therapy, there are different ways to treat them. So yes, smallest is the easiest way is to give oral contraceptive pill, which most of us usually treat it, either cyclical or long cycle, or only progesterone for a long protocol. Many a time what happens in these cases also, there is recurrences after certain time. Those cases actually probably needs a longer course of long-term medication of progesterone, either more than 1 year or more, or maybe GnRH analog with add-back therapy. So one interesting fact I am just going to discuss about what are the drugs which usually we use. So most commonly used drugs is all uses combined oral contraceptive pill. But one interesting finding is that this is not an approved indication for endometriosis, but we all use it, and it definitely it helps, especially in adolescent girls as well as young married women who are not desirous of fertility at this moment. This helps in reducing dyspareunia, as well as helps to stop the backflow bleeding. NSAID is another group of drugs, because endometriosis is an inflammatory, basically inflammatory condition. So there is a lot of prostaglandin release in the peritoneal cavity. So to suppress this pain and to become a chronic the patient, to prevent chronic pain symptoms, we can use anesthetic for a short duration of treatment. But this should not be used for a very long time. Danazol, we all know, it is one of the most important, once it was the most important drugs which is used for the treatment of endometriosis, but because of its severe androgenic side effects, now no more it is used. So coming to the GNRS analog, this is one of the mainstay of treatment in the medical management. It is definitely a very good the medical therapy, but the main drawback is that it's because of its hypoestrogenic function or side effect. It it causes a lot of problem like hot flash, vaginal dryness, decreased libido. But most important thing is that once we use it more than 3 months, there is a lot of bone mass, then a loss of bone mass density. And after 6 months, a great many women has got osteoporosis. So it is always recommended that if we use GNRS analog, then we should start at the therapy at least after 3 months. And one important thing is that the GNRS analog should not be used in adolescents because there is concern that sometimes this osteoporosis, especially in growth stage, so sometimes this can be a permanent thing, and we don't know about the long-term effects. And because of the painful injection, this its compliance rate is low and it is quite expensive also. But still, it is one of the mainstay of treatment. Then what options we have? We are left with in case of if for the long-term treatment is necessary, especially in case of recurrent endometriosis and progressive disease or deep infiltrating endometriosis. So theoretically, we know that estrogen hormone is a the proliferative effect on the endometrial glands as well as endometrial lining, and it definitely increases the endometriosis symptoms. So opposite to the estrogen, is the progesterone. So low dose progesterone, it represents the most effective treatment options for long-term therapy. And because a lot of studies has shown that there is gradual reduction in the pain symptoms if we use this low dose progesterone like Dynogest for a duration more than 1 year. So in Germany, this molecule Dynogest is the only progesterone which is licensed for use in the for the use of endometriosis. So what is the rationale for use of progestin in the treatment of endometriosis? As we have known that the progestin decreases the estrogen level, so definitely it reduces the proliferative effect on endometriotic glands and the endometrial cells, and it also leads to decedulation as well as atrophy of the endometrial tissue. Certain molecules like that progesterone has a immunomodulatory effect on the endometrium also, and progestin has also anti-inflammatory effect as well as anti-angiogenic effect, which helps in reducing the vascularity in the because we know some patients are very difficult to do surgery because of there are a lot of bleeding, especially in active endometriosis. There, if we use it beforehand, that helps in the surgery. So almost any progestin can be synthetic, can be used in the case of endometriosis. But the most commonly used molecules are like dydrogesterone, then Dynogest, and medroxyprogesterone. These three molecules we all know that they are most commonly used. And other progesterone molecules in the form of combined oral contraceptive is also used. So oral contraceptive, though we use it in endometriosis because it has got a small amount of estrogen, so definitely it should not be a very ideal treatment from the pathology. If you see the pathophysiology of the disease, as because estrogen causes endometriosis or it increases the intensity of the endometriosis, probably instead of combined oral contraceptive pill, a pure estrogen fits into the role in a better way. So we have seen that continuous use of progesterone reduces the endometriosis related pain in almost around 80% of cases. So this progesterone can use in two levels. Either it can act on the local level in the pelvic area, or it can act on the central effect also. So this Dynogest is the fourth generation among the progestin, which is commonly used. This Dynogest is the fourth generation progestin, and it is now one of the first line of treatment for endometriosis. And one advantage is that it has got minimal androgenic, estrogenic, and glucocorticoid, mineralocorticoid activity, and it has a very high bioavailability, and it doesn't have much interaction with the hepatic binding globulins. So either after surgery or as a first line of treatment, this should be one of the first choice. So in this slide, you can see that the Dynogest have got the local action like anti-proliferative, anti-inflammatory. It increases the immune, and it inhibits the aromatase enzyme also, thereby decreases the formation of estrogen from androgen. And by a central action, it has a moderate GnRH suppression effect, thereby decreases the release of FSH and LH and leads to anovulation, and thereby decreases the severity of the endometriosis. So in this review article, they have mentioned that this among the different progestin molecules, probably this novel molecule Dynogest is one of the ideal agents. So after surgery, the several study has been done. Use of Dynogest after following the surgery, and especially in perimenopausal women, and they are being treated with Dynogest for around at least for 6 months. And one study they have tried for 6 months, and around 9 study they have studied for 12 months to 43 months, and the recurrence rate is found to be very low. It's almost around 3%. So post-operative suppression with Dynogest following endometriosis surgery is associated with a very low overall recurrence rate, and is superior to no post-operative suppression. Suppose there is a patient had undergone surgery earlier, or some treatment was taken for endometriosis earlier, but again we have seen the recurrence rate. So it has been seen that if we start this Dynogest in the early stage of recurrence, we might be able to avoid second loop surgery. As we have discussed earlier, that the more surgery we do, however great surgeon we may be, once we do the enucleation or cystectomy, we tend to lose lot of normal ovarian tissue also, and thereby decreases the ovarian reserve capacity, where we can know by noting the AMH level. So we should try to do to avoid the repeat surgery. So here the role of Dynogest is there. So in this study we can see that among the there are 3 groups. One is no treatment was given after the surgery, one was given oral contraceptive pill, and one is Dynogest. So after 2 years, the recurrence rate with the Dynogest is only almost nil recurrence rate. But after 5 years, the recurrence rate is around 8%. It's much better than the oral contraceptive pill or no treatment given. So Dynogest improves the quality of life. We have seen it because the pain and other associated symptoms are decreased, and its safety for the long-term use has been well established. There are a lot of study they have given up to 5 years also, and personally I have also used more than 2 years also without much effect. Initially, actually for the initial period for around 6 to 7 months, there may be some problem like some GI intolerance, then a little bit one most important side effect, or rather not exactly side effect, but problem is that breakthrough bleeding initially. But after 3 to 4 months of continuous use, usually it decreases. So it's a better option than GNRS analog for long-term use because of side effects with the GNRS analog. And so we should start it immediately after when we detect it recurrence. And if we use it for more than 12 months, there is we can see a significant decrease in the size of the recurrent endometrium. And complete resolution of recurrent endometriosis is seen in around 50% of the cases. So there is one study where diagnosis is used for painful symptoms of adenomyosis. Again, adenomyosis per se, we have to first categorize what is the problem with the adenomyosis. Whether patient is having only pain is the only symptoms, or they have come for the fertility enhancement. So if they need fertility, then we have to assess the adenomyosis in a proper way, see how much actually effect on the endometrium. If adenomyosis is not very big enough, then probably we should not delay it giving any sort of treatment like GNRS analog or diagnosis. Because even if you use this product during this the treatment in medical management, what happens? Their fertility they cannot become pregnant, and once this treatment is stopped, once this treatment is stopped, what happens again? The disease might recur. So if we see that the pain is not very severe and adenomyosis is not very big enough, so probably we should try to make them pregnant by either by some ovulation inducing drugs or some other therapy as soon as possible. But if their concern is not for fertility, then the role of diagnosis is there. So when we have seen the diagnosis is used for around 4 months, and we have not used any drugs for 4 months, the pain substantially decrease after 4 months. And especially if the initial baseline pain is very much, then their improvement is much better. So there is one study which is done in Asian women for improving the quality of life with the diagnosis. So here they have assessed diagnosis after giving diagnosis for 6 months, and they have seen that if the initial pain is very much the basal pain, then the response to diagnosis is much better than not much pain in the initial report. So this indicates that improvement of quality of life as well as endometriosis associated pelvic pain has improved on diagnosis therapy. Therefore, it should be used as a first line of therapy for long-term management. We have seen it in this graph. The major improvement is the pain and emotional well-being after giving diagnosis for around 6 months. This is one publication where they have used for various time frame up to 1 month, 1 year to almost around 5 years, and they have seen that it is quite effective and safe for preventing the pain and tumor recurrence. But at the same time, they have got without developing any osteoporosis or hyperlipidemia. So one study they have compared the effect of diagnosis and the treatment of endometriosis, and the progesterone group, they are used to it 10 milligram twice daily for 12 weeks, diagnosis for 2 milligram per day for 12 weeks. The pain reduction is similar in both the groups. So because dydrogesterone is one of the very old molecule which we all know, these are being used for endometriosis and other little things. So this molecule is also equally effective. But one advantage of dydrogesterone is that if patients are contemplating pregnancy also during the course of treatment, so this is the first choice. Otherwise, we can switch over to Dynogest also. So when you compare the Dynogest with the medroxyprogesterone acetate, the depot formulation, Depo-Provera, so when they have used it 150 milligram intramuscular every 3 months, along with the Dynogest, the primary outcome is the pain scores before and after treatment. And it has been seen in this graph, in this table, that Dynogest scores better than medroxyprogesterone in all the symptoms like menstrual pain, chronic pelvic pain, dyspareunia, dysphagia, etc. But the major improvement has been seen in the menstrual pain as well as dysphagia. So satisfaction score was higher with the Dynogest than medroxyprogesterone. So in conclusion, Dynogest is more effective than medroxyprogesterone in treating symptomatic endometriosis. But I must say one thing about the medroxyprogesterone, especially the cost factor. In a poorer country like us, when we have to treat it for a long treatment and the fertility concern is not a major issue, the Dynogest, the depot medroxyprogesterone scores better than the Dynogest. And that can be used even every 15 days, 3 to 4 doses also. So, as we have already discussed about this Dynogest versus gonadotropic releasing agonist, the main advantage of Dynogest that it do not need any adback therapy, it do not have any osteoporotic effect, which is a major rate limiting problem with the GnRH analogs. So that can be used for more than 3 to 6 months. How long we can use it Dynogest? As we have seen in other slide also, so up to 5 years also they can be safely used. So if you compare the summary, in summary, if we see the different molecule which is used for the management of the endometriosis, if you compare the different molecules like Dynogest, glycerylin, leuprolide, and other molecule, the main advantage seems to be that it has got very minimal side effects and it can be used safely for a longer period of time. Only problem is that the cost is a little bit factor. And second thing is the initial period there can be little bit spotting. So it's in summary, it is a 4th generation Dynogest, is a 4th generation progestin, which is helpful in the management of pelvic pain associated with endometriosis. It reduces pain as well as endometric lesions also. It can be safely used for more than 2 to 3 years also, up to 5 years also. There are studies. And it is also helpful in reducing the extragenital lesions as well as deep endometriosis. It can be used in some cases of adenomyosis where surgery is not being done. But I must say, I am fortunate enough that I have assisted Talukdar sir in doing several very bad cases of adenomyosis surgery, and it's a really if you choose the case nicely, the very rewarding surgery, almost 80% they improve with the surgery, complete surgery. But we have to rightly choose the cases where to do the surgery, where to go for the medical management. So it's a higher efficacy in the long term than leuprolide and lesser side effects like hot flush and vaginal dryness in compared to leuprolide. So as we have known, it's an indication we all know: endometriosis, ovarian cyst, adenomyosis, and extragenital endometriosis. Those also, there are different doses has been prescribed, but now standard is prescribed is 2 milligram once daily. Usual dose is usual duration is for 3 to 6 months. Thank you.
Thank you, Diganto. The paradox of treatment of endometriosis is choosing between surgical and medical management. As you rightly have said, previously we had mostly surgery and we had medicines which had a lot of side effects. And after Dynogest has come, I think this is something we have really been using. I have personally been using Dynogest for a very long time. I think I was one of the first to start using Dynogest, and I've used for a very long time. And I'm very happy with the results. Only thing I have an issue here is that, and you have rightly mentioned that irregular bleeding is a real problem with Dynogest on long-term therapy. And sometimes they won't just go away. Just like, implanted Mirena or other thing, it is a very, very big problem. And the problem is to choose the right treatment, what we want to do with the surgery or medical treatment. You know what, that there's a saying that if you, the only tool you have is a hammer, all problems will start looking like a nail. So good surgeons are always offering surgery to each and every endometriosis patient, whether first recurrence, second recurrence, doesn't matter. But people forget that you have paid so much of those damage. So surgery, I believe, should be the last option. And the first option, if the patient is infertile and with endometriosis, they want to go for confused. And there are some questions, if you may, because one or two question is related to you, that how long after, say, infertility, if you had the surgery is for infertility, when you do, how long after surgery you do go for ovulation induction?
Immediately. Next one onward.
Immediately. Is there, because there is a lot of controversy, somebody would say that, 2-3 cycles of GnRS analogs should be given for better result, or some would say that no, immediately we should give that without waiting. What is your opinion? Because you get a lot of these patients.
So around 10 years back, that was the treatment model also we have used. Immediately after surgery, we used to give GnRS analog or danazol, whatever may be the thing, and to prevent recurrence, especially. But if I see retrospectively, at that time our skill of the surgery was limited, because that time recurrence rate was quite high. So probably we have not been able to do complete surgery, and for that thing actually you need to do the suppressive therapy. But once the surgical skill has increased and you can completely remove the, not completely, but you can do a very good surgery. So the initial the fertility peak, actually it increases within first 3 to 6 months. But yes, again, case to case basis. Suppose in case of surgery, there is a lot of studded endometriotic spots in the pelvis, probably, and you are not being able to burn those things. Probably there you need to give GnRS analogs or any other suppressive therapy and follow that with ovulation induction. But if the pelvis is more or less free, you have only few cysts which is you have included, there is no point of waiting. You just immediately, either you can just allow them to become pregnant naturally for a few cycles, or you can just go for ovulation induction immediately.
Okay. Another thing is that safety of dinoxazine in adolescent patients, one could say adolescents, and I think we can safely give it in adolescent. Another question, few people have asked about safety of dinoxazine if the patient inadvertently becomes pregnant. And the pregnancy question will not come, I think, because it's going to stop ovulation. Ovulation. And another is, can we try dinoxazine in early adenomyosis from Italy, Burman? We have already said so it could be used. And there's a pertinent question when he said that what is the effect of Dynogest in terms of the cyst size when you do start using Dynogest, because the medical management depends to, it used to say 3 centimeter in cyst diameter, now it's been brought down to 3 centimeter diameter. So can we use Dynogest in cyst bigger than this?
Yeah, you can use it. That is another. Suppose a adolescent girl, she has come with 5 centimeter cyst, and we are by radiological modality as well as tumor marker, we are almost sure that it is endometriosis. Then definitely we are going to use Dynogest also. I am not going for surgery as far as practicable. It doesn't matter whether it is 5 centimeter or 6 centimeter. For me, I am not going to go for surgery until she actually I will try to delay the surgery till she become adult or she marries.
Because cyst size, what we have, I have also seen, because my policy is to categorize patients into two types actually. One is a young, as in a young adolescent or young adult, which is not married.
Yeah.
Fertility is not a question.
Mm.
And the married women whom fertility is a question. In this group of people, if you use Dynogest and drugs like this, even if the size is bigger, there's market reduction in the pain and other problems, and the size do become smaller, and they can remain like that. And in this sense, although you have already said the question of oral contraceptives, oral contraceptive for maintaining is also not a bad drug. Only thing is, what I have found is that instead of 21-day cycle, you have to make it 42-day cycle. So if you give 2 packs together, there is a better control of endometriosis. But initially, you cannot start OCs. Initially, you have to start something like Dynogest. Suppose you for 6 months to 1 year, and if the breakthrough bleeding is a problem, then I have seen that if you switch over to OCs and all that, OCs with a little higher estrogen content, then we have a better control of this. That's just, I think your opinion will be better because you get more patients.
Yeah, and sometimes in Dynogest, suppose there is breakthrough bleeding, we can, instead of 2 milligram, we can use it twice daily for around 15 days, and it stops the bleeding. Then you can continue. But sometimes it doesn't help. In that case, we can just add the estrogen.
I have tried that, but even then, it sometimes doesn't stop. The patients keep
In
calling.
that case, OC may be again substitute for
you must have
cycles.
same things. So, any input from?
We are very happy that Dr. Aloka Kusam ma'am is there from beginning to last. So please unmute Aloka Vaido for her expert comment.
There are two Aloka Vaidos. I think both Aloka Vaido can come.
Kushami ma'am.
Yeah, I know, but
yeah, Aloka Das is also there. We will be happy to listen to both of them. Aloka Vaido?
Ma'am, is she
okay?
Alaka Goswami?
Yes, yes.
Yes.
I have Dr. Alaka, can you accept the unmute option? I have sent a request for unmute.
Oh. Aloka Vaido?
Just unmute, madam. It is there in your screen.
Yeah, I have sent her a request. She has to unmute herself.
I am asking
she has
madam only. Yeah, done. Oh.
Actually, I always attend this meeting, try to attend if there is no problem. But today I am very happy to see you all.
Yes,
and I congratulate both the speakers because of their nice and elaborate subject. But endometriosis is a very tricky thing. Presently, there are two conditions, I think, for gynecologists. One is endometriosis, another is PCOD. Yes. And so many drugs are there till date. But I think, to my mind, these drugs need prolonged treatment, especially dinogestanol, and the effect and prolonged treatment, and moreover, there are side effects also. And in all these groups of drugs, the outcome is very difficult to say for endometriosis. So both surgery and medicine till date is necessary for the treatment of endometriosis. And some cases are very rather, some miraculous things happens in endometriosis. In some cases, we see it is a very bad case. You are doing treatment, we thought that there will be no pregnancy, but that patient comes with pregnancy. And in another thing, there is, say, we hope that patient will come up very well, but though the treatment is successful also, but so far the fertility is concerned is very difficult. And another thing, to my mind, I have seen in my period, that sometimes internal examination is a very important part for the diagnosis of endometriosis. Sometimes I have said, it is my feeling, I don't know whether some others has also taken it. Sometimes we feel that there is some thickening in the
Good evening.
PCOD.
Yes.
But
Yes.
in sonography, there is
It doesn't show.
no positive findings for endometriosis. But after 3 or 4 months, you will see that is a case of pelvic endometriosis.
Yes.
So I think that if we get such cases, then I think we should start treating. And some of the cases of infertility also, I have seen that there is no, say, symptoms, other no complaint also. If we treat with an anti-endometriosis treatment, presently dinogesterol, after the treatment is over, if you wait for 3 to 6 months, patient gets pregnant. So there may be some element there which is not actually clinically or with diagnostic aid, it is not diagnosed, but there may be some cases may need treatment when we feel that there may be, the cause may be of slight pelvic pain and others is maybe a case of endometriosis. But one thing I want to tell that why endometriosis is increasing so much. In 1987, I was in Australia. Then there is in the conference that said they said that the first when there is a pelvic pain, first you diagnose endometriosis. Then if it is not, then you treat for PID. But I told that in our place, we treat for PID first. Then if there is no relief, then and then only we go for endometriosis. Hardly in my student life and as a PG or as a as a resident surgeon when I joined the job, hardly we see very almost in a year 1 or 2 cases only. But it is definitely it is increasing nowadays, and every third or fourth case is a case of endometriosis, especially in the younger group. So I think it needs needs some proper clinical assessment and diagnosis should use some diagnostic aids also so that we can early diagnose and help the patient, especially for pain and another thing for fertility. That is the most difficult things to do and to satisfy the patient. Thank you. I feel very happy to see you all, and I want that this type of, now in this days of COVID, this type of conference you should continue. Thank you.
Digonto, I want to ask. Okay. Digonto, I want to ask one question. Have you ever have to do operation after using diagnosis, and any difficulty encountered?
Endometriosis. I can tell you there are lots of difficulties in addition, especially with adenomyosis and pelvic endometriosis. One case, she was an infertile patient, till I remember. She feels so much pain. Then ultimately her husband and she asked me to do a hysterectomy. I prepared for that, but there was so much addition. Then I called one surgeon, and then he told me, by the way, I will just do a colostomy. If you proceed, then you will do lots of injury to the colon. So I'll do colostomy, then you do the hysterectomy, and then afterwards I'll do the rest part. Then patient was so happy. She told me that next day that I can stay with this colostomy. Now I have, my pain has gone and I'm very happy. She has got no complaint, or she never cried that she has lost her uterus. And many cases we got, but nowadays I think due to laparoscopic surgery, it has become easier than open surgery in cases of endometriosis.
Thank you, ma'am. Thank you, ma'am.
welcome.
বাইদেউ আপুনি যেটো কথা কৈছে আমি পুৰণা কথা যে pelvic examination, because pelvic examination for us you also taught us that we do it, but young generation wants to replace the TVS probe with the fingers, so it is very difficult to teach young people the art of the pelvic examination. But by the way, as rightly said, we can control the symptoms of endometriosis, but the creation of fertility is another factor where Diganta and other people are there, because we have seen that IVF is a boon for people with endometriosis, and if we can induce a pregnancy by whatever method, and our basic problem is solved, because pregnancy.
Thank you.
So one thing I just wanted to bring up, Ratnada, one particular we have found in the last 6 months, I think we got quite a few cases where hysterectomy was done for endometriosis, meaning, and there was a chocolate cyst or whatever, dysmenorrhea, pain, and then hysterectomy was done, and then the patient came to us with bleeding, vaginal bleeding and pain, and we found large nodules.
It will happen with hysterectomy if you do it in young people. I mean, suppose that case.
They have done the hysterectomy from above, but this main thing is this along. She must have had it earlier also, no?
Yeah, vaginal implants may be there, no, Ayana?
If I am allowed, I want to say another thing. People used to use herbal medicines, and few cases also I have used, and not in all cases, but few cases they responded very well. One case was referred to me by that is almost a frozen pelvis by our Dr. Nahata. He told that I can't operate, but you can go to Baido. She can give you some other herbal medicines, and I gave them that. And after use for 3 months, pelvis was completely clear. So many people, they used to use that herbal medicine, but get relief, but not all. I don't know how it acts and why it is so selective in treating, removing the causes, actually endometriosis. Herbal medicine is very simple. I think I still remember. They used to take this. আমি যে কম মানিমুনি শাক আৰু এটা তিনিপটীয়া বেলপাত আৰু এডোখৰ হেৰি কেঁচা হালধি ৰাতিপুৱা সেইটো মিলাই পেলাই তাহাঁতি পানীটো খাই দিয়ে 1 ঘণ্টা পিছত কিবা লাল চাহ আৰু শুকান ৰুটি নে কিবা খাই তাৰপিছত আৰু সব খাব পাৰে মই যিমান দূৰ মনত আছে সিমানটো আৰু মই কেইগৰাকী মানুহক দি চাইছিলে নাহাতৰ কেছটোত কিন্তু একদম এক্সেলেন্ট ৰিজাল্ট একেবাৰে পেলভিছটো ক্লিয়াৰ হৈ গ'ল কিন্তু তেওঁলোকৰ ইস্যু নাই সেইটো ঠিক আগৰ পৰা বহুত ট্ৰিটমেন্ট কৰিছে নাই তাৰ পিছতো আৰু মই আৰু অন্যখিনি ট্ৰিটমেন্ট কৰা নাই মই কেৱল এই হাৰ্বেল মেডিচিনটো মই কি জানো নাজানো কিন্তু মই এনেকা এটা পেশেন্টে মোক কৈছিলে মই আপোনাক দি চাব পাৰো আৰু এগৰাকী ইয়াং ছোৱালীক দিছিল আফটাৰ ওভাৰিয়ান সিস্টেক্টমি আকৌ সৰু এটা হেৰি হ'ল তেওঁৰ বিয়া হ'ল কিন্তু তেওঁ সেইটো খাই তেওঁ প্ৰথমতে সিলে মুছলিম লেডি গাৰ্ল সেইকাৰণে বেলপাতটো খাবলৈ ভয় কৰিছিল কিন্তু মই ক'লে এইটো একো চিন্তা কৰিবলগীয়া কথা নহয় মাকে একচেপ্ট কৰিলে তাৰপিছত তেওঁ কিন্তু তাৰপিছত তেওঁ 3টা বাচ্চা হ'ল তাৰপিছত ৰেকাৰেন্স নাই মই লাইগেশ্যনো কৰিলো তেওঁ পিছত 3টা থাৰ্ড বাচ্চাটো পিছত 3টাই নৰ্মেল ডেলিভাৰী থা কাৰণে দিগদাৰ হোৱা নাই কিন্তু ক'ব নোৱাৰো কিবা আমাৰ হাৰ্বেল হেৰিটো কিবা এফেক্ট থাকিব পাৰে কিন্তু এটো কোৱা টান কিন্তু কেটামানত মই পাইছো এই বস্তু
বাইদেউ ৰিসাৰ্চ লাগিব ভালকে
না আসলতে আমি আয়ুৰ্বেদিকৰ লগত লগ লাগি পেলাই মানে হেবিলাক অলপ ৰিসাৰ্চ কৰি চালে কিন্তু বেয়া নহয় মই একেবাৰে মানে ডেফিনিট ক'ব নোৱাৰো পেশেন্ট এটাৰ ৰেকাৰেন্সৰ পিছত এইটো খাই ভাল হোৱা বুলি কোৱা কাৰণে মই এতিয়া বস্তুটো লিখি পেলাই থৈ দিছিল কিন্তু মই 3-4টা কেছত মানে ভালে মানে ৰিজাল্টটো পালো আৰু নাহাতৰ কেছটো কিন্তু মই আচৰিত কেনেকে ইমান ভাল হৈ গল মই নাজানো একদম ফ্ৰী পেলভিস যেটো ফ্ৰোজেন পেলভিস তুমি হাত দিলে আচৰিত হলা হয় একেবাৰে মানে হেৰি হৈ ফুল হৈ আছে কেৰা হাৰ্ড এটা একো নাপাওঁ আৰু নাহাতৰ পঠিয়া দিছিলে বোলে এইটো একো কৰিবলৈ সামা সেই পেশেন্টে খুব ভাল ৰেসপন্ড কৰিলে কেন অলপ আমাৰো এইবিলাক মানে
ইমান টনটনীয়া ভইচ আছে
কম্বিনেশন উইথ আয়ুৰ্বেদ
লৈ যাবা
এটা চাব লাগে